Hi, everybody. Welcome back. I don't know if there's a lot of people from last week. I'd just like to point out last week when I did my presentation, I was in my 50s. I'm now in my 60s. So if I forget some things, you'll know why. But anyway, let's crack on. Um, this is about neck and shoulder, supposedly, but it's a too big a subject to actually really cover both things. There is an overlap to a certain extent, but I want to really concentrate largely on the neck, and we can have another session really going to the many different things which can be going on in the shoulder. But there is still something which is so fundamentally tied into the neck and the shoulder, which we will cover anyway. And the slides I'm going to just present now, it'll start on the neck. It will then go onto the shoulder. We'll go through all those very quickly. But then I think what we need to do is get onto the practical side. And again, as I explained last week, it's not so much the pain, but it's the causes of pain. And there's some very basic things which will work for shoulder and neck, which we'll cover as well. And another big area is educating your patient, making the patient understand what the problem is, because unless they understand, they're never going to actually do the things which you really want them to do. Anyway, with no further ado, let's just try and get in to share this presentation here. This should work. Hopefully it does work. Right. Right, we need to... Right, guys, just if I can have a thumbs up, Phoebe, if you can see the screen there. Right, brilliant. Okay, you can hear me, you can probably see me in a little box somewhere, but this is the presentation. Sidi Physio and Celtic SMR presenting. Nobody likes a pain in the neck, so you can see I'm concentrating mainly on the neck. But this is why we're here, because Acer Laser, they're the manufacturers of this unbelievable little tool, which we'll use in all these things. And that's, they provided these various slides. There's a few Italianizations, but don't worry too much about that. Okay, we're looking at the spine and primarily the cervical spine. These, again, I'm not trying to teach you lot how to suck eggs, because you know these things. But our big thing in neck pain or shoulder pain is diagnosis, working out what is the problem and looking at differential diagnoses and not getting confused. So working out what it is. Obviously neck pain, non-specific neck pain, whiplash, arthrosis, cervical herniation, protruding invertible discs, where we're getting a mechanical problem where we're putting pressure on the nerves, which leads to what they term as a cervicobrachialgia. Basically, a cervical radiculopathy, and they're often very easy to find, very easy to see. But what we must also understand, in any of these conditions, there's going to be, if you have a cervical radiculopathy, there is going to be a massive amount of muscle problems around there at the same time. And it's a great chance to use the laser as well, not only on the cervical radiculopathy, but also on the muscle spasming, trigger points, etc. Neck pain, it's just a massive problem in the general public. 54% of the general population will have some problem with neck pain. What they say is only 1/3 of patients reach complete resolution of symptoms. That's not the case here. I would put it at 90% more get to complete resolution. More common in women after 40 years, often the etiopathogenesis is not known, and therefore the condition is only indicated as non-specific neck. Very important, that last thing, that is, as far as I'm concerned, completely rubbish, because there is no such thing as something which is just not known. And that's our job as clinicians. We work out forensically what is the problem, because all pain is caused by something. And we can very simply go through things and work out what it is. Things, predisposing factors, well, obviously trauma, sports injuries. I've had plenty of neck problems in the past. Some of these can get really quite bad, and there was very recently a Premiership rugby player who had a cervical partial occlusion of his of the spine, but he's made a massive recovery. So thank goodness, things are going well. Professional conditions. The big problem in our life is everybody's on a computer. And that is going to lead to one thing which we'll talk about later, which is the biggest predisposing factor of any of these problems is, guess what? Posture. And there's a very simple way of just looking at how we can actually correct that. Psychosomatic features, we're getting to an area which is very real, but it's not my area totally. And cervical spine degeneration. So any of you lot out there who are over the age of 40 will have some cervical spine degeneration. And that's why I hate this idea of people just going somewhere, getting x-rays. What is the way? It's a waste of time. All you're going to see is some narrowing of the disc space anyway, because there will be some degeneration, and people have MRIs. It's just not going to reveal anything. We use clinical diagnosis, and that's how we find out what's going on. Okay, neck pain assessment. I'm not going to teach you how to do this. It's very simple. We look at the whole thing. Probably the biggest thing you can actually really look at is your SOAP notes straight away. Your subjective is so important in doing this. We find out what's been going on, how's it continued, how's it got worse. And then we do our objective stuff, which is very important, but the subjective is massively important. Let's move on. For a cervical radiculopathy, I suppose the go-to test is always the Sperling test. I'm not going to teach you how to do it. We'll have a quick look when I have my in the practical side, but that's a pretty good indicator straight away if we have a cervical radiculopathy, because the pressure down, as we turn the neck to one side, put pressure down, it will actually increase the symptoms, and then that's a little sign, wow, we've got a problem. When we're doing the Sperling test, we're actually moving the head back, twisting around like that, and then the pressure comes down. If you have a patient who's just rotating the neck, they have pain, sometimes a little bit of a sign of a stenosis, which might be causing some nerve root compression. But basically, that test is the one, it's the gold standard really for testing if we have a radiculopathy. Okay, if the tests are positive, it is better to require treatment. Now that's the Italianization. Basically, get the thing treated straight away. There's all sorts of weird things that happen. We want to keep away from sending people to, as much as possible, from the spine docs, the consultants, because there's so much of this. They'll get I don't know, sometimes steroidal injections, all sorts of stuff, and they'll generally just send us back to us. But anyway, rest, taping, manual mobilizations, active range of movement exercise, strength exercises, stretching. We all know that, but then they put down here MLS, Hilterapia, which is another form of laser they have, magnetotherapy. We're looking at MLS here, okay? You'll see in the further sides the treatment they put down MLS at the end. Especially in a cervical radiculopathy, I'm going to actually, once I've diagnosed that, I'm going to use the MLS straight away. And the very simple reason is, yes, we have a mechanical problem with compression on a nerve root, but so much in the very acute stage where they are saying, I am 10 out of 10 in pain by any movement. The biggest problem, and this pain largely, apart from the ridiculous symptoms which are there, but your general pain is coming from all the chemical mediators out there which are causing the problems, your prostaglandins, your bradykinin, everything. These things are causing, do you remember back at science when they used to put the sodium in the water and it'd go mad? Well, that's exactly what's happening in your body with all these different chemical mediators reacting against each other, and they're causing huge amounts of pain. And so this MLS laser has a fantastic ability to actually reduce the inflammation, reduce the pain in the situation. And once we can actually calm them down a little bit, then things like your manual mobilizations are just so much easier. What's happened here? My system seems to have stopped working. I'm just going to come out of here and I'll come back in there. Stop the share. Right, I'm back in the room, yeah? Let's just try and share that again. I don't know what happened there. An old computer. Right, I think we're back on that same page. Oh dear. Not too much of a problem. Right. Here we go. Am I back? Can you see the screen okay? Right. Most common after 40 to 50 years. Incidence does increase with age. Women have a higher risk. Here's a lovely little picture of your basic degenerate spine. This is what's happening to all of us, I'm afraid. But particularly around here, it's looking very, very nasty. The disc is becoming very degenerate. It's much narrower than it should be, really, which then has an effect also on the intervertebral foramen, where the nerve root comes through, and that is made much smaller. Nice little moving picture here. Again, if tests are positive for cervical arthrosis, are we talking about degeneration? Yeah, there will be. It's the same old thing. All these various points to put down, MLS at the end. We can, without a radiculopathy, we can try some of these other things. But again, I would often go to MLS at the start and then provide some of these other little modalities. Vertebral disc disease, which you saw in those pictures before. It says here, cervical level, the most effective area is 5-6. Yes, but also if you get the real compression on that, just from the disc disease, as I said, the intervertebral foramen will be narrowing. So quite naturally, you can get some compression in that intervertebral foramen, which will then start causing some radicular pain as well. So the big thing is trying to get rid of all the inflammatory mediators and try and do some manual work to try and open up that area. Assessment, pathophysiology, disc herniation, compressive forces can result in varying degrees of microvascular damage. Again, the MLS laser is shown to increase the blood flow, increase the capillary level regeneration, and it will actually improve all these things. The nerve irritation may induce production of inflammatory cytokines. As I said before, the MLS laser gets rid of these. Normally out the back to one side, and that's why we only have one side affected. If we have a patient who comes in with both arms in major problem, then you send them straight down to A&E. Again, disc treatment comes down. MLS at the end. We're going to probably do that first. Okay. If you have a radiculopathy, know your dermatomes. It just helps with our diagnosis so much quicker. Know your dermatomes, know your myotomes. They will actually very strictly show you the exact level. Probably the easiest thing of all, though, knowing which level. We said C5, 6 is the most common of these levels to be affected. C5, 6. Just ask the patient when they come in. They're in terrible pain. Ask them if they put the hand and rest it above their head, does it ease the pain? And if they say yes, you know we're actually probably talking about C5, C6. And this is a great thing. If we know exactly which level it is, we'll do a palpation as well and everything. But if we know exactly what level it is, then when we're using the MLS laser, we can go directly to that point and work on it. Because you've got to understand there is so much radiation of pain and symptoms with a radiculized problem. We want to get to the source of that problem. Dermatomes, know your dermatomes, myotomes as well. Quickly, I want to very quickly go through the shoulder stuff. Very important here, big muscles involved here. Here we've got the trapezius muscles, the upper traps, very important. Mid traps, incredibly important because they control this shoulder blade. They're very, very important. If we just, the rotator cuff muscles, your infraspinators, very important. We'll see why in trigger pointing, teres minor. We just take a layer away of muscles there. Oh dear. It seems to have frozen again. Don't worry too much. I want to go into the practical stuff here because I'm just going to stop the share. Come off here. Right. I should be back in the room. We can look at all sorts of things which are problems in the shoulder. What we know is lesions of different kinds. We know rotator cuff problems. We know instability of the shoulder, where the glenohumeral joint is not held in the right place, so too much movement in there. There are a load of things which can cause problems, but at the end of the day, it's going to be this other thing, which is a big problem, which is the same for the neck, which is posture. And I'll get onto that straight away. Right. So if we have a radicular problem, we'll do our investigation. We'll find out what the problems are. And let's, for instance, we say it's C5, C6. If we bring our patient in, what we do, if you can just sit down there, please, Francis. What we'd often do is, with the patient, treat them lying down. What I try and find is slightly better, is actually to try and get the patient sat up. If we've got a patient with a radicular problem, any movement like that is going to cause them massive problems. If we can get them comfortable, sat up, then it's a great benefit to us. We'll come over to our laser here. And if we can just get that onto that, I'll bring that round. Right, hopefully you can all see that. Okay, I've got this set up for the Charlie head. For the, just the handpiece here, using the wand machine, what we can do if we just got that, if we've got a cervical problem, we'd just probably go straight on the brachial neuralgia. Again, what's quite important to understand is the settings on this machine gives you everything you want. 500 hertz, 8 minutes, 50%, 6 points. It's going to show you the points which we would deal with. However, what we want to do is always probably do a scan of all the global muscles around there which are having a problem with this. It's an acute situation, scan, and what it's going to come up is 300 hertz, 4 minutes, 25%. It gives you a rough guide of where we're going to actually treat this. in this in the brachial neuralgia, I'd probably concentrate much more on one side than the other, because that's the side which is causing us problems. But there will be big problems on the other side as well. If we have the Charlie head, I'll come on to that later, but we can use that with the wand at exactly the same time. And what we'd probably do is just on the side, which is a real problem, let me just go over to here too, onto the neck. And I'd probably go on a muscle contraction here. It's slightly higher hertz than it has for the scan, but it will really release all the muscles. 5 minutes, 1 point, and we'll stick it in there and probably have a second one just come out here. So we'll really try and reduce all the tightness and the spasming of the muscles. But just to go back to the handpiece, if you don't have the Charlie head, acute scan, 300 hertz, 4 minutes, 25%. We just start. Okay, make sure you've got your glasses on. I'm just going to get those out. And give those to the patient and make sure you've got yours on. And what we'll do is we'll come around onto the patient. And it's always better if they don't have quite as many straps as we've got here. But we just start it, and you can probably see, if I put this on now, there's the laser. Now what I would be doing here is, I'll bring this down a little bit, and I will be coming all the way down. Light pressure onto the area. You have to be very careful with the patient in this situation. Generally, if you bring their head over here, it will probably cause a massive problem. So get them in the most comfortable position they can be, and then just scanning around all these areas and up and down. Okay. Hopefully you can see all that I'm not in the way. You're not supposed to do that. Going around here, all the way up the neck, down here, and so. Right, now I'm going to stop that now because I don't want to waste time here because we've got a lot to go through, but that will just go on and stop itself when we finish the scan. When we do the setting up for the stop it there. When we want to go into the pathology setting, we come off here, brachial neuralgia, 500 hertz, 800%, 8 minutes, 50%. If, again, it's set up very nicely, and this will be a very acute situation. If this had been going on for much longer, we could actually increase the joules which are going in, 7.646 joules per square centimeter. Very simple ways of doing that. Just by going 75%, we've put it up to 10 joules. We're getting a little bit more intensity in there. And there is always the way to whack it an awful lot of joules in there by going the continuous setting, where we're going up to 22. Do not do this unless you've tried it on lower levels for a long time, because otherwise you're liable to get a rebound effect where your patient will feel a little bit worse afterwards. But let's go slightly, let's say she's had a bit longer than a few days. Let's go 75%, and then we literally just start it. And as I get that going, you can probably see now the time is coming down, the joules are going in, we're on 6 points, but after it's 8 minutes, but after about 1 minute 25, it will actually just stop. So I'm going to bring it around here, and what we know is we were on C5, 4, 5 or 5, 6, whichever we decided, and we've got it right in on the area. Now what we're going to do is, it will stop, and that's it, stops now. Okay, we'd go around to here, just right around the area. Again, it will automatically stop itself. I'm going to stop it though to save time. We'll come right around here. So we're getting right around the area, which is a problem. There'll be 4 points there. And let's say this is causing problems on her right. Let's say we've done the 4 points there. If you can just, you wouldn't do this with the patient, but just for the sake of the camera, you can stand up, Francis, and just come and sit down there, around here. And then, obviously, with the brachial plexus, we're coming right down into this region here, and we'll probably get another 2 points around here on the front. And so on like this. The whole thing will take 8 minutes. And so on till it stops itself, which it will do. The 8 minutes will go by, and hopefully we'll have calmed down the problem enough to be able to do some physical modalities on her. Just want to change this. Right, now, physical modalities, we've just got to try and open up that intervertebral foramen. What I would do, having done the laser, I would get the patient, if we can, to lie on her back. Making sure that there isn't too much pain. I would get the seat belt around my shoulders. You can probably see here, I'm putting the seat belt around my shoulders. And what I'll do is, I'll just do some distractions on the patient. We can take these off now because we're not using the laser. Get the patient down, you won't be able to do that. I'll lift up the head, be very careful, okay? Let your head go, let your head go. Switch off all these muscles, okay, completely. Just behind the C-spine. I'm gonna pull the, gently I'm gonna pull out the pillow, and just from here, I'm now going to do some sustained distractions. Now, the patient has probably got the really bad pain in the right arm. What I would say is, if you feel a reduction in the pain, then lift up your left arm when we do this, okay? I'm going to probably do loads of, well, 5 or 6 30-second holds. And if you're feeling a reduction in the pain, lift up your left arm. Okay, that's good. So we know it's working there. If we have an increase of pain, they will let me know, but this will often just make a big difference, okay? So 5 or 6 30-second pulls on there. Okay, when we're finished, just let the patient down. Let your head go. Okay, and then we can eventually get them up. Okay, right now, I want to stop looking at the radiculopathy, and I want to look at this general neck problem that we have. Neck, and it will be shoulder problem as well. If you come down, Francis. The biggest problem is posture. Right, so what we'll often say to our patient is, try and make them understand the problems that there are. If you could sit down in the chair. Okay, now, Francis has come in this situation. with just general really bad shoulder, neck pain coming up here, and probably some nasty headaches as well. Why is this happening? Posture is the big problem, okay? Now, a great way to make them understand is, she's looking very worried, but I'm going to get this big weight here, okay? And I'm going to put this on the shoulder there, and that is digging in a bit, isn't it?
Yes.
But could you sit there for a long time with that if it wasn't digging in?
If it wasn't digging in, yes.
Yeah, okay. Could you hold that in one arm?
One hand.
Okay. And could you hold the arm out there? How long can you hold that out there?
Can't.
She can't. She can't hold out there. Right, why can't she? That is 4.5 kilograms, okay? Why can she hold it here all day, but she can't hold it out there? And it's very simple. It's the very first thing that we learn in physics. It's levers, okay? So once we put it out there, the center of gravity is way back there. So the pressure which is coming through here, through the shoulder and everything to hold that up is massive. Now that is exactly the same weight, believe it or not, 4.5 kilograms, 10 pounds, as this thing. So when people are sat around on computers with the head forward and anything like that and looking over a computer, the muscles which are holding this up are the levator scapula, the upper trapezius muscles, some of the mid-trap muscles, and they are going crazy. And you're getting all sorts of nasty things like trigger points, and which will cause a huge amount of pain. So if I can just go back, if it works, I just want to go back and show you that we sometimes get conditions which are confused with radiculopathies. GPs will send people down to you. If we can get, let's say, this one. I'll put that up. Right, hopefully you can see that. These are the myofascial trigger point referral patterns of your infraspinatus. In your infraspinatus, which is in your shoulder blade here, there's usually areas of trigger points which have a very specific referral patterns. A little bit on the inside of the scapula, but into the arm, this could be mistaken straight away for a C4, 5, 5, 6 radiculopathy, and even some pain coming down into the hands, okay? This is trigger points. Right, how do we sort out the trigger points? Well, we've got the most incredible system here on the computer. Not on the computer, on the MLS laser, which is here. I can just get back into here. And right, we're going to stop all the stuff we did before. Okay, when you get your screen up here, you'll probably see, hopefully you can see this, is trigger points, okay? Press on your trigger points. It'll come up 100 hertz, 20 seconds, 25%. Okay, what we can do here is we just get this going. We get the glasses back on. And if you can turn around again. All we have to do is we press start here. Now, it's all ready to go, but you probably see the lights on here. The laser's actually not working yet. Let's work out exactly where these trigger points are. And we can find them so easily. Just go into the infraspinatus, the spine of the scapula there. We'll go into the infraspinatus. Feel around, we'll get a taut band. So let's see if we can actually find it right here. I'm going to put a bit of pressure on there. Have you got any pain coming into your shoulder and down your arm?
In where you're pressing, yes.
Yeah, coming down the arm, yeah? Right, okay. Right, well, it's so simple. We now have found a myofascial trigger point right here in the infraspinatus. Yes, she said it hurt a little bit where I was pressing, but then she started getting the pain all the way down here and to the hand. What we do is, we've got the thing all set up here. We find that trigger point again, which is right there, and we go on here, okay? And we just leave it on there for about 20 seconds. Hopefully you can see where we are here. And after 20 seconds, it will just stop. Stopped, just press in again. Is that as bad as it was?
No.
No? Okay. Right, this, honestly, you've probably seen from this patient, I haven't coached her in any way, but just straight away, that has actually reduced the problem straight away. Probably all we would need is 2 or 3 little points, messing on the trigger points here, and we will get a massive change. Right, what's it like?
Fine.
Is it all right?
Yeah.
Okay, right, well, I'm not making this stuff up here. And as I say, this is a very hard patient to please. So, that is your trigger point setting as well. So, we're going to have to move on because we need to get some questions going. And there's an awful lot you can ask me and go on about if you want. But for treating a radiculopathy, for teaching general neck pain, there is a massive, massive advantage by having this laser, because it will actually sort these things out. What we still need to do is actually use your clinical skills. But with this, as an adjunct, it's just a phenomenal piece of equipment. Right, I'll hand it back to you, Phoebe, and if there's any questions, just ask me. I think you're on mute.
Yes, sorry, I've just unmuted myself. I couldn't find the right button. Yeah, so if anyone's got any questions, I've got one question that came in earlier on. Is there any evidence that laser is better than other electrotherapy modalities for treating these symptoms?
Well, there's all sorts of different forms of electrotherapy. In terms, sorry, I'll just say ultrasound, of course there is, because whether that works, well, yes, if you kept it on for weeks, it might do something. Yeah, there's a huge amount of literature. And I would refer you back to Celtic SMR, because they have got all the stuff from Acer Laser and everything regarding so many different pathologies where they've done scientific scientific work which have shown that the improvement with MLS laser, the class 4 laser, is actually quite stupendous. So I would refer it back to you guys, and you can send anything out that's needed to who anybody wants it.
Thank you. Is there an advantage or point when you would go to biostimulation prior to settings in pathology? Does that make sense to you?
Say again, sorry, repeat that.
Is there an advantage or point when you would go to biostimulation prior to settings in pathology? Maybe.
Are you talking about would I do the pathology before the scan?
Possibly. Maybe I'll ask the lady to ask that question.
Well, if that is the question, no, I wouldn't. I would always do the scan. Always look at the global approach first. So we do the scan first to actually reduce all the, we'll get more blood flow, more thermal action within the tissues around the problem, and then we do the pathology setting afterwards, and that's the way I would always do it.
Fine. Someone else has asked, when using the wand, when is it necessary for the patient to wear protective glasses? I would assume
they always, because really, I suppose the big danger is, just make sure it's definitely off. if I point that in my eye with it on, I'm going to cause some retinal damage, some probably partial blindness. If you leave it on there, you'll blind yourself. Now, when you saw me using this, you probably saw a bit of red coming out. Infrared light, you can't see. That redness is just, there is an LED in there which is just showing you to specify where the actual point is going to, but you can't see infrared light. The other thing is, I've got all sorts of little things on here. Even the desk itself here is metal. There's all sorts of metal around there, and it can very easily bounce off these things around the room, a bit like a bullet ricocheting, and it could still go into the eye even if you're not pointing it at them. So always have your glasses on, both the patient and the clinician. There is a laser sign which you'll, when you get this, you stick it on your door to make sure that people don't walk in. And if they do walk in, you've always got this little button on here. If it's in action, just stop it, bang. Just press that very quickly and you won't cause any damage that way. But we have to take safety to the ultimate level, because the last thing you want in any situation is to cause some damage when you're trying to treat somebody for another problem, and that's what you just don't want. So just wear the glasses. You can't wear any glasses. You've got to wear these specific glasses which actually cut out the infrared light, and I think they're probably 745 to 1115 nanometers. And that's what we're doing. And since we're actually going between two levels, 805 and 808 and 905, it's completely taken out. So there is no danger whatsoever.
Great, thank you. How does laser compare to shockwave in clinical effectiveness?
I would say this is possibly so much more effective. The reason being, they work on completely different bases. Your shockwave is causing increased inflammation because it's causing you tissue damage. It's doing a very similar thing to your, let's say you have an Achilles tendinopathy. And this is a part of the reason why I brought this in the first place, because I was looking, shockwave 6-7 years ago was a big thing. Yes, it's very effective, but it's only effective on real collagenous, tendinous areas where what we're doing is we're breaking down the tissue. In terms of a tendinopathy, your collagen is all laid down like that, should be elongated like that. Your tenocytes have become big and round, not long and thin. What you're doing is you smash this, and then it will start a new inflammatory process which will allow the collagen to repair like that, which is exactly what an eccentric loading program will be doing at the same time, which we know is very effective. This is actually working on a completely different basis. This is reducing the inflammation. This is sending in the infrared light into the tissues itself, into the cells. At a cellular level, it's increasing, it's starting through a protein synthesis, the production of ATP, which is the powerhouse of the mitochondria, which starts a natural repair process to repair them as they should be. It's as if the cells are completely out of battery, and now we regenerate them, and because they're all damaged, they actually start healing themselves in the correct way. Now, the big difference between this and shockwave as well, let's say on a tendon, is this is not painful, whereas the shockwave is not always 100% tolerated by people. It can be very well tolerated. Some people cannot tolerate. And the big example I'll use of that is our good friend Anthony Watson, the England fullback / winger, British Lions and England winger, who ruptured his Achilles. When he came back in training and rehab, he was having shockwave, and he re-ruptured it again, and he couldn't really tolerate the shockwave. He had a second operation, so the tissue is actually even worse, And then we got him back using this MLS laser back to being faster, quicker, better than he ever was before. And so that's my big selling point in terms of the tendinous structures. This is also can be used on so many soft tissues where we're not talking about real collagenous things. It can be used for different things. It can be used for neuropathies. It can be used for trigger points. All these things, which it can be used for edema, corks, muscle corks, everything like that. You wouldn't stick a shockwave therapy on somebody who's got a massive cork on the thigh because you'd probably kill him. Whereas you can use this by changing the settings. And so what is the difference in efficacy? Well, I suppose they both work very well, but this works on so many more things than the shockwave can do.
Cool. For a cervical spine pathology, would you still use the 3-2-1 protocol regarding number of treatments?
Well, yes, I would, because that has been shown to be the most effective way we can. Look, I understand not everybody can do the 3-2-1. You know, somebody says, you know, you get people who say I can only come in once a week. You're still helping them, but with it being cumulative, if you can actually whack them, especially somebody who's got a really quite severe radiculopathy, and in fact, just when the shutdown happened, I had a patient rang me out who said, I'm in 10 out of 10 pain, shoulder pain. And I said, look, we can't see you. He said, no, it's 10 out of 10. I said, nothing's 10 out of 10. He said, this is 10 out of 10. So I suddenly thought, well, hang on. And I asked him, you know, any ease if you bring your hand above your head on your shoulder? And he said, yeah. So, well, straight away, it's not his shoulder and it's a radiculopathy. And we are allowed, I had to dress up in all my PPE, but we're allowed to see people to stop them going to A&E or the GPs. We got him in, we used the laser straight away. I did some distractions and he rang me up 2 or 3 days later and said, I cannot believe what you've done. It's just amazing. I feel great. I haven't seen him since. That's not a good advert for business because people aren't going to get much money. But I saw him once, and the fella is screaming my praises from the rooftops, and that was just once.
Fantastic. You mentioned issues with seated posture. How about an ambulant posture? Thinking specifically about LLD.
Well,
that doesn't make any sense to me, but I'm not a physio.
Well, the big thing about the seated posture is if we can, it depends. In a radiculopathy, there are so many problems. I mean, the pain can be so excruciating. But we can generally get them sat up in a position where we can get them comfortable. If we start moving them around all over the place, we can be causing irritation of that area just by movement, closing down the intervertebral foramen. I would also just, once they've eased up and we've got it calmer, it might be sometimes very nice to get them on the bed and actually do stuff around with them in a more comfortable position. The other thing which I like to tell people to do is when we start this off, the very first time, I'm probably going to have this completely, the body still treating on there. As we're able to, the pain is going down, I want to actually start mobilization while this is going on. Sometimes passive, sometimes active. We want to open up, get them moving as we're actually doing this treatment. And that is probably something you'll bring in after the second treatment, once you've had the big change straight away. If you start trying to get them to do active or even passive movements in the real acute situation, they're going to be going crazy and probably not come back and see you because they'll be in a lot of pain.
Okay, I've got one more question outstanding. With regards to cleaning the glasses and COVID, what the best effective way of cleaning them without damaging them?
Right. With the glasses, just any alcohol wipes. That's really what you want to do. We're not really supposed to use alcohol on. They recommend probably not using an alcohol wipe on the laser head here. What I always do is I'll do wash everything, clean everything around here, alcohol wipe around here, but just put a like a wet wipe around here on the end of here of the handpiece. However, this is something which is probably actually it's a good point to make here. Francis, can you come and lie on your front on the bed? No, because you can have your head through there. And we're not going to get this going. But look, we're at this very weird juncture. We've got all sorts of tricks we can do, but we are so limited at the moment because of this social distancing. Everything. If you're whacking somebody with a shockwave, you're right next to them. If I'm using the, we should be able to get there to do it fairly soon. But there'll be a lot of patients. You've always got to think of the patient, and they might not be happy about having some piece of equipment stuck on them like that. I was showing you with the Charlie head here that we can actually use it just as instead of the scan. This is actually exactly the same. But a much wider area. We can have the settings exactly we would for the pathology setting. And so if I can just bring this back, and I'll try and show you here, it's a pretty amazing piece of equipment because what we can do is we keep our social distance from the patient, and we're all basically set down here. But I can keep the social distance massively here, okay? If I want to make sure I'm really keeping my leg, I'll just get there, change that there like that. And then I've got that in that area there, okay? And I don't know if you can see, but I'm bloody miles away from it, okay? I'm 2 meters. I'll go 1, 2. I'm over 2 meters distant. And I can actually then do any treatment I want at a distance and don't have to worry about any contact whatsoever. Don't bring your head up. I don't have to worry about any contact whatsoever because I've got this amazing piece of equipment, which in the current climate, you know, even if people don't want the Charlie head, it's something which I just think is so useful. I can do anything I want without touching people and keeping my social distance.